Hey, my name is Palone, and today we're going to talk about what I do at a cardiac arrest. Okay, so the first thing I do when I arrive to a cardiac arrest is I like to announce respiratory is here. I go to the person running the code and I let them know, hey, respiratory is here, because we've all been there where there's a lot going on and they're asking, where's respiratory? And you're like, I'm right here, I'm standing right next to you, right? So I think it's important that they know that respiratory is is in the vicinity. Like, we're here, we're part of the team. Second thing I do, which is very important, I go and I make sure that we are ambling with the right size mask and the right size ambu bag, especially when it's pediatrics and neonatal. Those things are very important. Now, this third thing right here, make sure this ambu bag is connected to oxygen and the right flow port, and it is turned up flush all the way, and that if you're using a bag that's supposed to be inflating, that bag is inflating efficiently. You cannot believe how many times I came into codes where the ambu bag is not connected to oxygen, or it's not even turned on, or it's connected to the 50 psi. But either way, right? That's our job. We're gonna make sure the patient is getting oxygen. The next thing I do is I offer to bag the patient. If they're good or they don't need me to bag the patient for whatever reason, I'm now gathering things for intubation if we need to intubate. Oh, also with the ambu bag, make sure that if the patient requires PEEP, that the PEEP valve is on and is dialed to the right number, no, to the right setting. Okay, sorry. Darn it. So the next thing I do is I offer to ambu the patient. If they don't need me to ambu the patient, I will gather the supplies for intubation. Now, I'm going to insert a list of what we have in our code cart box, and I want to highlight the things that I definitely want there at intubation. So a few things I definitely make sure to keep my eye out for is an easy cap, a 10 cc syringe. What else? I like to make sure I have my ET tube holder, or if we're taping because it's pediatric or neonatal or whatever. But yeah, it's just certain key things I just make sure to have, because sometimes, let's say it's nursing who's grabbing all these supplies, they'll they don't grab those things for whatever reason. So right before we intubate, I like to make sure that we have all those things. And if for any reason all those things, those key important things, which I think I put a star on that list, is not there, I will stop and say, hey, we can't intubate yet. We need such and such. Okay. Also, here's a quick tip for the code. I do not believe in saying, hey, we need a 10 cc syringe, and expecting some random person to catch that yell and then go grab this 10 cc syringe. What I like to do is I like to look at someone directly and they know I am talking to them. Hey, can you go grab me a 10 cc syringe? I'm not asking some random person in this code. That is very inefficient, and it's not the best way. I don't think it's the best way. Yeah. So the next thing that I do, all right, I like to make sure we have everything there. After that, right before we intubate, hopefully they did a timeout, and I like to make sure everyone knows. When I say I like to make sure, it doesn't mean I'm saying these things to my coworkers, to the team. I like to know that everyone knows what the next step, who's doing what. So if for any reason during timeout they didn't mention who's going to be listening to breath sounds after, like once the cuff is inflated and we're bagging, I like to ask, hey, who's going to listen to breath sounds? That takes care of the problem right away, just like that. So I usually just ask, hey, who's going to pull out the stylet? Hey, who's going to inflate the cuff? If she didn't mention it during her timeout and saying, this person's going to do this person's going to do that, who's this person going to do this? Because I like to know what's expected of me and what you want me to do, instead of us fumbling while we're at the airway. It's not good for the patient. It's not good for my stress. After that is right. So once I know definitely what we're gonna do, and now we're about to intubate, I do my part, wherever that is, whether that's removing the stylet, inflating the cuff, connecting the easy cap, ambling the patient, securing the tube. And as far as securing the tube with an ET tube commercial, with the commercial ET tube holder, I like to do that personally. I feel like a lot of physicians and nurses are not really aware of that little tab. I'm going to insert a picture of that and circle that, of the tab that's there to adhere to the ET tube, to make sure to make sure the endotracheal tube isn't sliding up and down. During that process, while I am securing the tube, I like to over communicate. What does that mean? I like to say, "Hey, I am securing the tube. Hey, I'm sliding the straps behind the head," because I think it's important that if I'm adjusting or moving this patient's head in any way, the person holding the tube is aware and they adjust accordingly with the tube as well. Does that make sense? Yeah. So that's that. Patient's intubated. We still haven't had Ross. I'm bagging the patient. And even if I have a end-tidal CO2 waveform going, for intubation, I still like to have an easy cap. I think that's the best way to make sure we know we're intubated, and we're going to use a capnography to indicate when Ross has returned. Okay, Ross has returned. Yay for the patient! Yay for the team! Right? Good job, guys. Um, Now I'm going to connect the patient to the ventilator. If I don't have the ventilator already set up, I either have someone else bag and I will set it up, or um, I'll bag and have a team coworker set it up. And not a nurse, not a PCT, not a physician. No, it needs to be another RT, because I have story time for days of things not being set up the right way because someone who is not within their scope is acting outside of their scope. So yeah, that's that. We connect the patient to the vent. I'm adjusting the ventilator settings. I'm adjusting alarms, and I'm basically cleaning up and taking my time now. When I say cleaning up, I'm not cleaning the area because it's probably a whole big mess. But I make sure I grab that ambu bag and the mask. That mask is still gold. Okay, you don't ever want to have an ambu bag without the mask. Then it's incomplete. Because if that patient ever loses that ET tube, like self-extubation, accidental extubation, you still need that mask to ventilate the patient. When I worked at a children's hospital, we would tape the mask onto the top of the ventilator, okay? Because that's how important the mask still is. So I make sure I get that and I put that away. And I'm basically taking my time because I want to stay around the vicinity to make sure when they do a chest x-ray, I'm still in the area just in case they need to adjust the tube. And also for that first blood gas, if they need to adjust any ventilator settings, I'm there, right? Let's say all those things are done, everything is great. What I like to do next is, and I'm ready to go about my business, right? I need to see other patients, right? Or I've been standing on my feet for like over an hour. It's time to sit down for a second, or I'm famished. I love how colds tend to happen right before I need to eat. But anyway, I'll find out who's the nurse covering, and I'll say to her, "Hey, the patient is doing such and such and such, like patient starting 100%, or say patient starting 85, 100%, people 12, there's nothing we can do. I'm getting all my return volumes. Peak pressure is this and this. Are you good that I walk away?" And usually it's like, "Yeah, sure, thanks." Um, and I like to tell the provider basically something similar to that as well, because if they want me to make any adjustments or settings, they'll tell me right then and there instead of me just walking away without them knowing. And now they need me there because the tube's too deep. The tube's not deep enough, or these settings are not good. We need to go up on this. We need to decrease that. And then has to call me and come back to the patient. I think if you try implementing some of these things, you'll notice some of the improvements between the nurse RT relationship. You'll notice like your workflow it's going to be less interruption during your downtime. And I know that that's huge for me. Okay, let's do a quick recap. First thing I like to do, I like to let the team know that respiratory has arrived. Second thing is I check the ambu bag and the oxygen connections. Third thing is I either ambu the patient or assist with intubation. Fourth thing is I connect to the ventilator and I clean things up. I do my wrap up. The last thing I do is I communicate with the team before I leave the bedside. That's all, guys. Thanks for watching. Subscribe, like, and comment.